I use a 10% overcorrection for sphere and 15% overcorrection for cylinder with the rule. Drop socket. So you'll have to see that the ocular surface is very pristine. That's very important. And remove excess fluid before you dock. So this is the Visimax 800. The robotic laser arm comes down. So you always verify the name of the patient, the refraction. Yes, that's good. So it's minus 4.5 plus 2 cylinder at 100 degrees when it's transposed. Minimal thickness. Okay. So now we rotate the joystick to bring the gantry down. Drops. Always keep the cornea moist. So just before we dock, again I like to put some paracaine drops. Okay. The excess fluid is drained off either with a sponge or it's a prominent eye, then okay. The patient has an angle kappa of 0.439. So with the Visimax 800, you have the centration guide. So you can see the green flashing light. Just keep looking at the green flashing light, Spandana. So that's the fixation light. And as you come closer, and just as you applanate, then you change to the infrared, and then you can see the visual axis. The blue cross here is the pupillary axis, and the yellow spot is the visual axis. So there is almost, the angle kappa is quite large, about 4.3. So you need to bring the, keep looking at the green light please. So now we are on the visual axis, and you can see that the circle becomes blue, and then we dock. So you can see that it is less than 0.1 mm. The decentration is less than 0.1 mm. And then we have a markerless system, 2 diopters. Again, I'm checking with the infrared image of the iris here, and I see the iris marks here. Can you see the script there? I correspond it, it's perfect, there's no cyclotorsion in this case, so I don't have to rotate. But suppose there is cyclotorsion, you need to compensate, then you just rotate the joystick and you can rotate the pattern like this. But here, there is no cyclotorsion, so I'm just going to bring it back to 0. And then we start the laser. You can see it's just going to take 8 seconds. Don't move please, green light will disappear. Okay. You can see that the laser pattern is quite nice, and it just takes 8 seconds to make the refractive cut, the side cut, the cap cut, and the entry incision, which is 2 millimeters. I like to keep my entry incision at 2 millimeters, superiorly at 12 o'clock position. The laser arm goes up and the microscope arm comes down. IPD change ಮಾಡಿ 65 minus 2. Can you see the microscope view? Can you see the bubble pattern here? The bubble pattern is very good. So that is optimization of the laser lenticuloschisis. So I'm going to show you my technique of removing the lenticule. It's called lenticuloschisis, or a no dissection technique. You don't have to dissect the lenticule. You can just remove the lenticule just by the forceps. So these are my fixation forceps. It has 2 fixation arms to prevent torque. So I just hold the episclera there. I just enter with the jaws closed. That's the incision. You can see it's a 2 millimeter incision. Open the jaws on either side. I grasp the lenticule, and you see I push it down. just like how you do a capsulorhexis during your cataract surgery, you can do the lenticuloschisis here. You just grab the lenticule. You can see there it is separated, it's very pristine, you can see the edge very well, and you pull out the lenticule. I know the whole lenticule has come out, so that's easy and nice. So that is the smile technique with lenticuloschisis. Can you see the light? Spandana, look at the light, please. Okay. This is the slit lamp on the 800. I always check the interface. And you can see where you see a little bit of bubbles which disappear in the next few minutes. We just put a lubricant on the eye, and that is the end of the procedure. So you saw two new things today. One is the markerless system for cyclotorsion, where you can actually compare the infrared iris images and the iris pattern, and you can compensate for cyclotorsion. The second is the no dissection technique or lenticuloschisis for removing the lenticule. Thank you very much, and we'll move on to the next surgery, which is the clear surgery being demonstrated by Dr. Rajesh Fogla. If there are any questions, I can take them while we shift to the next OT. It's gone on well, Spandana. Just keep blinking normally. Okay, don't touch your eyes. Keep blinking.
Dr. Sri Ganesh, that was an excellent technique, wonderful, and saw the speed of the laser too. And any questions from the audience on that?
The Visamax 800 got recently FDA approved, so now it is FDA approved in the US. And I was part of the team that developed the Visamax 800, and we have been developing this from 2015. And I was this was one of the first installations of the laser. 5 sites selected all over the world to do the initial global trials, and we were one of the centers for the global trials. And we'll shortly be publishing the data.
Dr. Sri Ganesh, this is Dr. Norman Mendoza. Now, this no dissection technique, so how difficult to learn or any advantages?
You need a higher degree of skill, plus you need a very good pattern. So you need to optimize your laser. If you have any OBL or black spots, you can't do it. So you need to optimize the laser energy, and you can see the bubble pattern has to be very uniform without any OBL. And then also it needs some amount of dexterity where you can go and then grasp the lenticule and then remove it. I would not suggest it for beginners. Maybe if you have done about 500 or 1,000 eyes and then you optimized your laser, then you can try it.
Thank you, Sri Ganesh. That was a great, elegant surgery. And as far as the technique is concerned, my only comment will be that any technique in your hands looks very simple.
Thank you, Dr. Deva.
Sir, one query, sir. Sir, in regular smile cases, sir, do you suggest irrigation of the interface, or there is no need?
See, I normally don't irrigate the interface. Before, as a routine, I used to irrigate the interface, but then we did a study and we found that it doesn't make much of a difference whether you irrigate or not. In fact, we saw a little better results without irrigation, because then when you irrigate, the cornea becomes a little edematous and you can have a little bit of a refractive shift. So especially if there's some fluid remaining in the interface, but we don't routinely irrigate now.
Thank you, sir.
Thank you.